I'm George Baer with Nouvation Incorporated. Thank you for taking time out of busy schedules to join us today on this webinar. Nouvation is the creator of OTIS software for blood banks and laboratories. OTIS is the acronym for Occurrence Tracking Information System, a software system for tracking and trending deviations, also known as nonconforming events, for process improvement and regulatory compliance. It's my pleasure to introduce today's presenter, Randy German, Blood Bank and Laboratory Quality Manager at Hoag Memorial Hospital, Presbyterian in Newport Beach, California. And here's Randy.
Thanks, George. Thanks for this opportunity to talk a little bit about NCEs and KIQs, to use the acronym. So just in the way of some disclosures, I have no financial interest in OTIS or Nouvation. I am, however, an enthusiastic user of the program, and we were the development site for OTIS, and we continue to serve as the beta test site for new releases, and we're always asking for new features, and we're happy to test those out. Hoag's Laboratories Education Fund is receiving a small honorarium for this presentation. My objectives would be to review the regulatory requirements around nonconforming event reporting, and in the blood bank, it's known as blood product deviation reporting, as well as the key indicators of quality required by CAP, to demonstrate the use of NCE tracking and trending and how it drives quality improvement and the selection of what KIQs you monitor, to show how a NCE information system can help ensure regulatory compliance, particularly in the blood bank setting, and discuss root cause analysis in a blame-free or now known as just culture, and how we went about trying to develop that just culture. And then with the few minutes we have left over, I will do a quick demo of some of the OTIS features. So Hoag Hospital is a community not-for-profit hospital. We're a two-campus system, 500 and 100 beds. We are not a trauma center. We do a lot of deliveries, about 10,000 inpatient surgeries, and we transfuse about 25,000 blood components per year, 130 FTEs, and 1.5 million billed tests a year. And up till just a little while ago, we had a hospital-based donor center and donor processing laboratory. This is a picture of the Newport Beach campus. It's just across the street from Pacific Coast Highway, and tremendous views of the ocean up on the top floor, but like all good labs, we're in the basement, so we don't get to see much of the ocean, unfortunately. And this is our Irvine facility that opened 4 years ago, just about 10 miles or so from Newport Beach. Okay, what's our history with NCE reporting or blood product deviation reporting at Hoag Hospital? In 1992, we actually received an FDA 483 for really not doing a good job of following up on problems and documenting our investigations of blood product deviation reports and ensuring that the corrective actions were effective. In 1995, as you probably know, the FDA mandated electronic blood product deviation reporting for both blood banks and transfusion services. So in 1996, we developed a paper error and accident form in the blood bank and a paper problem report form in the general laboratory. We noticed in 2005 there was an increased emphasis put on BPD reporting during FDA inspections. In fact, often the first thing they ask for when they come in is, let me see your last 10 reportable events and your last 10 non-reportable events. They seem to be spending an increasing amount of time on BPD's review, and that's true to this day, at least for us in our experience on the West Coast. In 2006, we received another 483 for failure to report a BPD electronically within 45 days of discovery. And we reached out to Nouvation, who was doing some consulting at the time in another section of the laboratory, and asked them to develop a occurrence tracking database. And in 2009, we went live on that year in 2006. 2009, the ABB actually awarded us a best practice for NCE reporting, and then we rolled the blood bank system out to the rest of the lab in 2011. So now for the kind of the dry part of the talk, we're going to review the regulatory requirements around both NCE reporting and key indicators of quality monitoring. So CAP certainly requires a quality management system to identify and evaluate errors, incidents, and other problems that may interfere with patient care services. They have to be those identified internally as well as those identified externally from sources such as complaints from our customers, patients, physicians, and nurses. The program must be implemented in all sections of the laboratory and on all shifts. You must document the investigation and resolution of the problem. You must perform a root cause analysis of any unexpected event involving death or serious physical or psychological injury. And then an important note, or risks thereof, meaning you have to investigate both actual events and those that result in near misses. And you have to have risk reduction activities around those events that you're investigating. And then the CAP also has requirements, which is a Phase 2 deficiency, for monitoring key indicators of quality in all three phases of laboratory testing, pre-analytic, analytic, and post-analytic phases. And they should be compared against available benchmark data. And you need to monitor multiple aspects of the testing process appropriate to your scope of service, and those that are critical to patient outcome or may affect patients. And so I'm going to talk a little later about how we use our NCE tracking and trending to select our key indicators of quality, at least in part. And then there's no requirement for any specific laboratory monitor continuing with the key indicators of quality, and this was just revised on the most recent checklist. But there's a suggestion of things to monitor, and you can see that list here. So all those ones that you see there in orange are being monitored through our Occurrence Tracking Information System, or OTIS. And then on to the ABB standards, very similarly. Standard 9.0 shall have policies and procedures for data collection, analysis, and follow-up of issues requiring corrective action and preventative action. And there you see it again, including near-miss events. So even if the event does not reach the patient, you still have to investigate that. And we try to treat our near misses and actual events the same way, which we'll talk a bit more about when we talk about just culture. Standard 9.1 shall have process for corrective action of deviation, nonconformances, and complaints related to blood components, including a description of the event, investigation of the cause, determination of the corrective action, and evaluation to make sure those corrective actions are effective. And then the Joint Commission also has very similar requirements for event reporting. The hospital has an organization-wide integrated patient safety program within its performance improvement activities. Includes a full range of safety issues from potential or no harm errors, sometimes referred to as near misses. So there's that term again, near miss. And everybody's familiar with the Sentinel event policy. Any process variation for which a recurrence would carry a significant chance of serious adverse outcome. And you can see there that, again, you have to investigate near-miss Sentinel events. EO7, the leaders must define Sentinel event and communicate this definition throughout the hospital. And in the laboratory standards provided by the Joint Commission, the laboratories must also define Sentinel events for its purposes and communicate that definition throughout the hospital. Now, if you're using CAP as your regulatory agency that has deemed status for CMS, you probably don't need to do that because that's not a CAP requirement. The organization conducts thorough and credible root cause analysis and responds to Sentinel events and should focus on the systems and processes, not individual performances. And again, that's a key part of establishing a just culture, is that you're focusing on systems and not people. Reviewable events are any that resulted in unanticipated death or major loss of function. Specific events, even if they did not result in unanticipated death or major loss of permanent functions, there's a whole list of those, sort of like the Never 28s, that have to be reviewed by the Joint Commission, including hemolytic transfusion reaction due to major blood group incompatibility. However, reporting of reviewable events is voluntary, and JACO really encourages it because it helps them to put out practice standards and safety precautions to their constituency. And again, in the laboratory Joint Commission standards, all individuals who work in the hospital are able to openly discuss issues of safety and quality, and that staff suggestions for improving patient safety and willingness to report hospital events. So they're really suggesting you should be assessing your program to make sure that the staff feels they're able to report patient safety issues and that they're willing to do so. We actually are not a Joint Commission hospital. We're a DNV hospital that uses ISO standards. They have a standard for corrective action, very similar to the rest, that you review complaints and nonconformities, you determine the cause, implement corrective actions, and monitor for effectiveness, just like all the other regulatory agencies. So the FDA, in terms of blood bank, in 1984 came out with a law that said licensed blood bank must promptly report to the FDA errors and accidents that may affect the safety, purity, or potency of a blood or blood product. And then in 1991, they put out a new memorandum, responsibilities related to errors and accidents, and pointed out that they noticed that a large percentage of recalls are due to errors and accidents, reminded the blood bank industry of that 1984 law that requires us to investigate and report, and expanded the reporting requirement from manufacturing or donor centers to the transfusion services. So that happened in 1991 and left us all scrambling to implement that in hospital-based transfusion services. In 1995, they put out another guidance document on quality assurance in the blood bank, pointing out that knowledge gained through investigation of complaints of errors and accidents is essential to QA, and that corrective action should focus on systems or process redesign, retraining, and procedural changes. The term, at that time in 1995, the term error and accident was replaced with biologic product deviation, or BPD, and that's when the electronic reporting requirement came in that we have to report to the FDA within 45 days, and that BPDs, near misses, must still be investigated but don't have to be reported within 45 days to the FDA. I just wanted to recommend the Clinical Laboratory Standards Institute, or CLSI, to you all as a great resource. I'm sure many of you are familiar with it. It used to be called NACLS, or National Committee for Clinical Laboratory Standards. They changed their name in 2005 to CLSI. They have over 200 standards published, and it's just a wealth of information. They have sample forms, and they're referenced by many of the regulatory agencies. The CAP checklist has 25 other standards referenced, and the FDA lists over 100 of their standards in their consensus standards database, and JCAHO has a complete crosswalk of CLSI standards. It's not cheap, so $5,000 to get access to all of their standards, but they can be ordered individually for a fee if you didn't want to pay the annual fee. So a great source of information, and I referenced two of these when developing our policies in this talk today on quality management systems and management of non-conforming laboratory events. So I commend those documents to you. CLSI also has one of their 12 QSEs is on occurrence management. So let's get into the nuts and bolts of a good NCE system. What should we report? And I'm going to focus first on the general laboratory. We break our classification down into the 3 phases of testing. So here's some examples of things you should report in the pre-analytic phase. And it should be anything that has the potential to adversely impact patient care or accuracy of test results. So these are certainly some examples in the pre-analytic phase. Probably our number one NCE by far is specimen quality. Hemolyzed, mislabeled, clotted, contaminated. I'm sure you all struggle with that as well, so we report a lot of those, certainly labeling problems. Analytic phase could be quality control errors, reagent or instrument problems, incorrect results, or any time a result is edited, that is treated as an NCE, and we do investigate that. Post-analytic, wrong result filed, could be a data entry error, could be filed on the wrong patient. Anything to do around results transmission and distribution, calling of critical values, turnaround times not met, certainly any safety concerns and customer complaints, and we try to instill in our staffs that that's regardless of validity. So we don't try to make a determination, that wasn't a valid complaint. We report them all in our system and review those. Well, in blood bank, we refer to the 2006 guidance for industry on BPD reporting. And the definition we use is it has the potential to impact safety, purity, or potency. So if you put a extended expiration date, incorrectly lengthy expiration date on a product, that would be one that would potentially impact safety, purity, potency. If you put a too short of an expiration date, one could argue maybe that doesn't impact safety, purity, or potency. We actually report anything that affects the availability of that blood component, including a preventable blood loss in the processing lab. Certainly post-donation information is a big one for us, and one that has to be reported. And so what do you have to report to the FDA? Which of those BPDs are reportable? Their definition is if the product left your control. And so we've defined that in our operation. For donor collections, it's anything that's discovered post-donation. For the donor processing laboratory, it's anything discovered after the unit's been labeled and distributed to the transfusion service. And for the transfusion service, it's anything discovered after the unit has been issued to the nursing unit. So those are, based on those definitions, we consider those reportable, and we consider that those products have left our control. And again, we investigate near misses even if we catch them prior to them leaving our control, but we don't report those to the FDA. In pathology, some of the specialized areas, here's some examples from pathology department. They've broken it up into all common amongst all the areas of pathology: accessioning, histology, transcription, and cytology. I certainly won't read those, but the nice thing about the OTIS system is you can program each section to have its own set of codes to classify your nonconforming events. So we've developed some very specific ones for pathology, point of care, cytology, and really if we run into a new problem, for example, we just went live on computerized physician order entry, and we started having a problem of samples appearing without orders. So we built a code in the OTIS system for tracking, and we let staff know, hey, if you see this, report it in OTIS, and that allows us to provide data to the nursing unit. So you can build customized codes as new products come along, and if there's something you want to monitor for a short time. So CAP, AABB, and CLIA all have requirements for complaint reporting and anonymous reporting. So CAP requires you to have a procedure for employees and patients to communicate concerns about quality and safety. The laboratory must post the official CAP sign regarding reporting of quality concerns, and I'll show you what that looks like in a moment. The ABB, very similarly, shall have a process for personnel to anonymously communicate concerns about quality and safety. And CLIA, the laboratory must have a system in place that ensures that it documents complaints and problems reported to the laboratory and must conduct investigations. So the way we handle this is that the CAP, AABB, and CMS instructions for filing complaints and concerns are posted as hard copies in the laboratory and at our outpatient draw station, and then they're also on the hospital intranet. And then we have an anonymous login in our OTIS system so that if an employee doesn't want us to know who they are, they can log in anonymously and still report. Because the important thing is that they report, not that we know who did it. Excuse me. This is the official CAP sign, and you can get that off the CAP website. It's actually blue on the website. This is the AABB sign, and you can write or call that number to get one from the AABB. And this is the CMS pamphlet that's posted on our intranet, and that's the website for the PDF of that pamphlet. So let's transition now and talk about what makes for effective root cause analysis. So it always starts with a good report, and that's to write. And one of the things we have to instill in the staff is that you're writing up the problem, not writing up the person. And I can guarantee you when we first rolled out particularly the general lab OTIS program, we got a lot of tattletaling and this person didn't do this, and it was very personal, and we've had to really stress to them that we're after the problem so we can examine the system. This is not a means for tattling on people or getting back at one of your colleagues. They need to provide all the relevant facts and ensure sufficient detail for follow-up and risk assessment. And provide this. It's important that we develop a training module for how to report in the OTIS system and provide them with feedback if they're not doing a good job. And I'm going to show you an example in a moment of a good report and a not so good report. The first question you want to ask, or an important question, is the step in question covered in SOP, and was the SOP followed? So in the OTIS blood bank system, we're required to indicate which SOP is in question and highlight the step that was not followed. And if we can't do that, then certainly one of the contributing factors is likely that we haven't had adequate SOP. And then I can't stress this enough, if you're really trying to get at a root cause, you have to sit down and talk with the staff. And the only way to really distinguish between human error and incompetency is to interview the staff that was involved and really find out, did they know what to do? Do they know the right way to do it? And if they do, it was probably just an oops. And if they really don't, it was probably just it's likely a competency issue. Many times you'll get, well, I don't remember. That was 3 weeks ago. I have no idea. And that's okay. What you can do is have them explain, well, how do you normally do it? So you can still assess whether they're competent. And were there other contributing factors? Was there inadequate staffing that night? In this day and age of monitoring productivity and cutting FTEs, that can be good ammunition for you for justifying positions. And oftentimes, maybe there were multiple errors that lined up that contributed to this. So here's a good example of a report of a contaminated sample. Patient John Smith was drawn, gives the draw time, shows the results of the original sample, called the results to who and when, and mentioned that these results could indicate a contaminated sample. Venipuncture redrew it. The results were now normal. All results, and what did you do about it? All results in the prior draw were canceled and credited due to a possible contaminated sample. So I think this is a very good factual write-up that allows whoever is reviewing this to assess the risk and understand what happened. This is an actual not-so-good example. We had a contaminated sample, spoke to the nurse. She was angry the patient had to be redrawn. I told her it was our policy. So in the previous example, it was focused on the system. This one's clearly focused on an individual. They were more interested in writing up the nurse than writing up the facts of what happened. So this is part of the education that you have to do with your staff and constantly giving feedback to encourage factual reporting. In the NCE literature, you'll read about the 5 whys as a key to root cause analysis. And I love this example. The car won't start. Why? The battery's dead. Why? The alternator's not functioning. Why? The alternator belt's broken. Why? The belt was beyond its useful service life and not replaced. Why? The vehicle's not maintained. You didn't do your preventative maintenance. So we finally got at the root cause. It wasn't the battery being dead. It was the preventative maintenance not being done. And in this case, the systems improvement would be to make sure the preventative maintenance gets done. So keep asking those whys to drill down till you get to the ultimate answer. This is the failure modes effect analysis Swiss cheese model. I'm sure you guys are familiar with this. And the point of this is that when something reaches the patient and something bad that happens, it's usually a lining up of multiple failure points. In this case, the example is a mislabeled sample, and it started with the night shift tech called off. Venipuncture is working a double shift, which contributed to them taking multiple labels into the patient room and comparing only 1 of 5 labels of the armband. But the ultimate problem here was we're not generating labels from the armband. So the solution here would be to implement a positive patient ID system. But you can see how all of these factors lined up to have the error reach the patient. And similar analysis have been done in transfusion accidents as well. So we've talked about effective root cause analysis now. what makes for effective corrective actions? Well, one of the things the FDA shared with us early on is it's important to document the immediate corrective action. What did you do to keep that error from getting even worse once it's been discovered? In the case of blood bank, it might be, well, I gained control of the non-conforming blood product and I quarantined it. In the case of a mislabeled sample, it might be, well, I went to all the sections of the laboratory and secured all the samples, not just the one that I discovered in my section that was mislabeled. I think early on, one of the mistakes we made is we tried to implement a corrective action for every non-conforming event we had. And really, that's not necessary because a lot of them are going to be simple, one-off human errors. So you really need, before you decide on whether you're going to implement something significant like a systems change or an SOP revision, you have to look at trend data. So important. Does it occur infrequently? Or is it a trend by SOP, by employee, by air type, by nursing unit, by laboratory location, by the time of day even, by shift? So really, it's important, whatever system you're using, to be able to trend the data to drive the corrective action that you choose. And that's why I think having an information system is so important. And I'll show you how easy it is to trend in the OTIS system, which really helps us. Certainly, does the SOP need to be revised? And in our blood bank system, we are required to list what SOP step was involved in the error, and if we can't do that, then we are going to be revising or creating a new SOP. So it really keeps our SOPs current. Did equipment or software problems contribute to the error? Does the involved employee or other staff have suggestions for systems changes? So in the blood bank, we actually, every one of the BPDs that we investigate goes out by email to the entire staff every time it happens, without any names, but reminding them that, hey, we had an occurrence today. This is what happened. This is how you prevent it from occurring. This is a step in the system that's designed to prevent it from occurring. And do you have any suggestions for how you've incorporated safety measures into your own system to prevent something like this from occurring? So it really creates a competition around preventing and reducing non-conforming events and having this open atmosphere where they're all shared with everybody. Now, that's taken some time to evolve, but it really was modeled on after what the airline industry does with their error and accident reporting system. Maybe we need to dive a little deeper and find out, what is the extent of this particular error. I've got a suspicion this is happening to more people than we think, or it's happening more often than we think. So you might need to do an audit or an observational competency, which I can't stress enough how valuable actually watching your employees do a particular procedure can be. Or maybe the entire staff needs to be retrained. And again, that is indicated based on the frequency of what's happening. And again, as I mentioned before, avoid trying to develop a new system or implementing a double check. I'm not a believer at all in double checks until you can see that this is a trend. This has risen to the top of the priority list. We need to see if we can improve this system. And again, use double checks as a last resort. So let's talk a little bit about just culture, which I think is the most important tenet of an effective non-conforming event system. And indeed, JCAHO requires that the hospital provides and encourages the use of systems for blame-free internal reporting of a system or process failure or the results of a proactive risk assessment. So I think that term blame-free is a little bit out of date and has been replaced with just culture. And I'll go over why those two terms are kind of different, actually. So I think a just culture assumes good intentions so that every employee or most employees, 99% of employees, come to work wanting to do a good job. So when you're sitting down with them, remind yourself that and assume that that employee is wanting to do the right thing. and remind them the number of times that they do it correctly. You take a full-time employee in the blood bank and think about the number of data entry errors that data entries that they make in a one-year time period, and they have one data entry error in a month. That's a pretty good record. So a big part of in creating a just culture and investigating NCEs is to sit down with the employee and build them back up, because they're coming in already having beat themselves up and feeling bad. So you want to assume they have good intentions, and you want to remind them that they're a good employee, and that's how I always start my discussions. Absolutely no automatic link to discipline. When we first went live on BPD reporting, when the FDA started requiring it for transfusion services, we said, hey, if you have 2 BPDs in a year, you're going into corrective action. Well, it wasn't long before the entire staff was in corrective action. They were covering up errors. Nobody liked to talk about errors, and morale was really bad. So it serves no purpose to have automatic link to discipline, but I'll talk in a minute about when discipline is indicated. Really remind the employee that we are here to focus not on the error that you made, but the system that allowed that error to be made, and talk about, hey, is there anything you can do or that we can do from a system standpoint to prevent the likelihood from a recurrence. And then finally, to treat near misses the exact same way as you treat actual events. So we put no more credence on something that left our control as we do with the ones that we catch before they leave our control. We try to treat them the same way, and again, that's modeled after the airline industry. I talked about how we openly share all errors. We put out an email to the entire staff and solicit ideas to prevent recurrence. It's super important to celebrate successes. I think I've already talked about supporting the employee, restoring their confidence. Give feedback. So every time an employee, there's a field in OTIS for suggestions. Every time an employee makes one of those suggestions, it's important to give them feedback, even if you're not going to implement it. Sometimes people add things to their own system, a little extra safety check that may not be part of the SOP, and we'll share that with staff. Well, so-and-so has done this to make it less likely for them to make an error in this incident. So we do share that, and we definitely give feedback anytime someone makes a suggestion. And then to recognize, just recognize them for catching something and reporting it in the system. Certainly sharing data with staff is important. If they are constantly putting these NCEs into the system and never hearing anything, it won't be long until your reporting falls off. If they think it's going down in a black hole, they're not going to participate. So really show them how you're using the data, some improvements that have come out of the data, corrective actions, and particularly celebrate any suggestions that were incorporated into a system redesign. This is some of the data from our blood bank that we shared last year. We investigated 114 non-conforming events. There was sort of even division between the 3 sections of the blood bank. 10 reportable BPDs. 7 of those were not preventable. They came out of post-donation information reports. We had, most importantly, no adverse patient outcomes, and a BPD rate per unit transfused of 0.048%, or 1 in 2,000 units. So this is something we show to the staff and celebrate and say, look, there were only 3 PPDs. We had no adverse patient outcomes. Our mission's being accomplished. We're transfusing units with a very low error rate. So while it can seem punitive, you need to turn that around and make it into a cause of celebration with the staff. And then we divided up the BPDs by section. Health history interview errors were the #1 in donor services. Defective bags, we had a problem with one of our bag manufacturers. And in transfusion service, we had a particular problem around cord blood testing that we made one of our priorities for quality improvement in the following year. When we look at contributing factors, and again, you're not going to know this information real well unless you sit down and talk to the employee. I want to stress that again, but 79 were simple oops. They were simple human errors. We had 10 post-donation information, 7 unable to determine, and 6 times we determined that the employee really did not know what to do, and we did a retraining. 3 inadequate SOPs. We made 2 systems improvements and 1 equipment and supply problem around the blood bags. So out of all that, in our fiscal year 13, we revised 10 SOPs, did 10 retrainings, we notified the manufacturer, we made some systems changes, we started doing some real close auditing of the core testing errors, and shared that data constantly with staff, and that has improved a lot in 2014, and method validation around our Hariba instrument. So I mentioned that the old terminology was blame-free culture. That suggests that discipline is never indicated. You'll never be blamed for making a mistake. And really the new way of looking at that is just culture. And yes, I believe that, errors do rise to the point of discipline, and there's some particular times when that is true. And certainly impairment due to substance abuse, premeditated and intentional disregard for policy. I knew what to do. I knew that was an important point, but I was busy and I just refused to follow that. I think it's unnecessary, and I'm going to disregard that step of the policy. And we'll talk about critical control points here in a moment. Falsification of records, absolutely. Failure to report, including self-reporting. So if they're covering something up, that may be grounds for disciplinary action. You want to make sure before you discipline an employee that the step missed is in your policy. It's well understood and it's been trained. It's part of your training modules. The employee can always say, well, I was never trained on that. This is not in writing. Certainly at some point, repeat errors of the same type after attempts at retraining and competency assessment, you're going to have to say, we've done everything we can. You've had 3 of these. We've retrained you 3 times. You've shown us you were competent, but this error happened again. And so at that point, it may rise to the level of discipline. Critical control points. By that I mean a function or an area in a manufacturing process that which, if you fail at or lose control over, may adversely affect the safety, purity, or potency of a blood product, resulting in an unacceptable risk. And so, for example, critical control points that are pointed out in our blood typing policy is that you access the patient in the computer via the barcode label on the blood specimen prior to entering results, that all reaction tubes must be labeled with a unique patient and reagent identifier, and that you compare that identifier with the screen at the time of resulting, and that you don't enter all the results from memory, that you enter the reaction results as you are reading them, as you shake the tube or look at the plate. And certainly we know that most of our blood typing errors used to be resulting on the wrong patient. It wasn't a testing or technical error, and that's why we pointed out these critical control points. And these are not debatable or optional, so if an employee is purposely ignoring and consciously ignoring these critical control points, that could be grounds for discipline. So we try to point those out in our procedures that, hey, this is a critical control point. Please pay attention to this. It's for safety. This is another critical control point in blood issue. Our blood bank information system allows selection of the unit by clicking on one of the 2 allocated units, despite our pleading with them. But we require that the employee gets the unit from the refrigerator and selects the unit by scanning the DIN on the unit label. And for obvious reasons, they could grab the wrong unit out of the refrigerator and select the correct unit on the computer screen, and end up the wrong unit for the wrong patient is going up to the floor. So this is certainly one of our important critical control points that we've stressed during training, we stressed during our observational competency of the issue process. And if if an employee ever consciously disregarded this, and it was clear that they were trained on this, I would consider that probably grounds for discipline. How does the number of NCEs, or should the number of NCEs impact a performance review? Well, there can be no question that NCE data is an objective measure of performance. I mean, should the person that had 14 non-conforming events last year receive the same evaluation as someone that had 0? I mean, I think not. And the way we handle NCE data at the time of performance review is the criteria-based evaluation used to say, you've had no more than 2 occurrences since the prior evaluation. And we've changed that to, you respond in a positive manner when discussing errors, and you offer suggestions for error prevention. So We don't mention the error rate during an evaluation. We don't get out and review every NCE that was reported unless they're at either end of the bell-shaped curve. So if someone had 0, we're going to make a big deal of that at the time of the evaluation and use that as ammunition to give them a high score on one of the criteria. But certainly if someone's had 15 or they've had a corrective action throughout the year because of their NCE performance, we'll probably talk about that, and that will affect one of their scores. But typically, for most of the employees, we don't even talk about it. We don't bring up their error rate, again, unless they're at one of those two extremes. So let's switch modes a little bit from non-conforming events to key indicators of quality, which is a CAP requirement. Of Phase 2, you are required to track key indicators of quality in your laboratory. This is a look out of OTIS, out of our OTIS data for our shortened fiscal year 2014 at the top 30 laboratory non-conforming events, and this was trended with a couple clicks of the mouse. So you don't have to be a crystal report writer to get data out of OTIS, which I think is one of its best features. But in any case, we can see that, and I'm sure in your laboratory as well, sample quality makes up either mislabeled, hemolyzed, QNS, clotted, contaminated, makes up 60% of our NCEs in the general laboratory system, followed by incorrect results or delay in results. So all the red bars have to do with sample quality. We've made that a top priority for this fiscal year. We are working with a team from the ED to work on hemolyzed samples, a lot of which come from catheter draws. And so at the end of the fiscal year, we sit down and we do trending, and we select our key indicators of quality for the next year based out of that trending. Now, not every one of our KIQs is linked to non-conforming events, but certainly your non-conforming event data should be considered when you're selecting your KIQs. And if we look at our top 5 severity level 3s and 4s, 3 is potential harm, 4 is actual harm, we can see that contaminated samples is our #1 potential harm or actual harm to our patients. So we are really making that a priority this year. We want to have a benchmark of 0 for contaminated samples. They're easily prevented. Don't draw above an IV, right? Or clear the line if you're doing a line draw. So we are working in an interdisciplinary fashion with the nurses to work on eliminating or reducing contaminated samples. And then we do a similar thing with all the sections of the laboratory. So for microbiology, it was non-blood mislabels. So we're working on that. We're doing a little deeper dive at the MAIC on incorrect results. Those are just a couple examples. And we do the same thing for each section of the laboratory. And when you select your KIQs, just some tips. You want to make sure you can get at the data. So it should be something you can easily get at data-wise. You definitely want to target 1 or 2 based on your NCE trending. Select something that you're going to be working on in the coming year. So don't select an NCE that you have, select a KIQ that you have no intention of paying any attention to. Otherwise, you're just going to be doing data for data's sake. For example, we're going to look at mislabeled samples because we're implementing a positive patient ID, generate the label off the armband for our nursing draws, and we expect to see improvement. So why not select that as one of your KIQs? Similarly, they're implementing a barcoded specimen tracking system in pathology, so let's look at specimen ID errors in pathology. And certainly, your non-conforming events can be used to justify capital expense. So when we were going through the justification process for collection manager, we were constantly providing data on nurse draw mislabeled samples. We've already implemented it in venipuncture. It was very expensive to implement in nursing, but when we provided that data that we were able to get out of OTIS, that helped with the justification. So how do we do reviews of NCEs and KIQs? So in the general laboratory, the quality manager, the administrative director, and the medical director will review at a very high level OTIS trend data on a monthly basis. We look at all severity level 3s and 4s, that's potential and actual harm. We review any complaints, either from employees, physicians, or any of our other customer groups. The employee has the ability to flag an OTIS report for group review. So any that they flag, that's something they want us to see, so we'll review those. The medical director then electronically signs those, and you have the ability to add a note to an OTIS report, and if I have time I can demonstrate that. So if during our review we want some additional follow-up or actions, we'll add a note to it, and that will flag the reviewer in that section to take some more action. In the blood bank, our quality unit meets on a monthly basis to review all the OTIS blood bank reports. We certainly look for trends. We look for sufficiency of corrective actions. We tried to read them like an FDA investigator to make sure they're objective, complete, they're clear, and there's good verbiage. And we sometimes debate whether or not they have to be reportable or whether they rose to the level of a OTIS blood bank report at all. And then again, the medical director electronically, she signs all reports, whereas in the general laboratory ones, she signs only the ones we define for her to sign, which are typically severity level 3s and 4s and complaints. So for KIQs, after we select each section's what they're going to be monitoring for KIQ, they refresh their data on a quarterly basis, and they post it on a bulletin board that we cutely named the Quality Corner, and the medical director reviews and signs all of them. And then we have a different section present their data monthly at our Quality Council meeting. This is the sort of template that we use. I'll show you a completed one. This is one that we're looking at with blood bank samples without order. So we'll put the data, the background, the data source, which in this case was an OTIS nonconforming event code, the conclusions, and the follow-up and corrective actions. And then if we do a project around one of our KIQs, we use the DMAIC model, define, measure historical performance, analyze the process, improve the process, and control the game. There's others out there. Focus PDCA is another one. We are currently using DMAIC. Seems to be the acronym of the year for that sort of thing. So these are some of the KIQs we've selected for the next fiscal year. Again, some of them based on non-conforming events, some of them not. Incorrect results, massive transfusion protocol turnaround time. We monitor stat turnaround time. That does not come from our non-conforming event system. Contaminated mislabeled samples, cytology versus post-surgical concordance, pathology case turnaround times, pathology sample labeling and requisition errors, blood culture contamination rates, and confirmatory blood types that we don't always receive from the pre-op area. So a lot of these came from our KIQ trending data. This is sort of the quintessential quality corner, quality improvement dashboard. This is an example from not my facility, from another facility, which I'd love to get to someday, but this is sort of a green, red, yellow light. How well are you meeting your quality indicators? And then if you click on this link, it takes you to another spreadsheet where it has the detailed data. So we'd love to get to this someday, but just an example of a really neat KIQ dashboard. So I hope you'll bear with me. I tried to set up some scenarios here. So I'm going to spend the remainder of the time giving you just a little bit of a demonstration of the OTIS system, which is what we use for our non-conforming event. And I'm going to start with the product I'm most familiar with, or have been using the longest, and that's the OTIS blood bank system. Now, the OTIS blood bank system is a little more comprehensive than the OTIS lab system, and I'll kind of point out some of the differences along the way. We don't allow the staff to report in OTIS blood banks since these are reviewable and discoverable by the FDA. So our entire laboratory staff uses OTIS lab to do their reports, and then if they rise to the level of blood bank safety, purity, or potency, a member of the quality unit is the one that writes up the OTIS blood bank. So let me show you a little demo of the OTIS blood bank system. This is what the log looks like, and this log is configurable in any way that you want. But let me open one up. I think it'll make a lot more sense if we just dive into one. So OTIS is a series of tabs, and on those tabs are little red and green LEDs, and all the tabs that are pending up here at the top. So if you look at the status at the top, it's in status GIJT. And so the goal of the game is to turn all the LEDs red and to turn all the LEDs green, thank you, George, and to get the report into status Z, which means it's complete. So the different tabs have different information fields. So the first tab is the discovered by, who initiated the report, who discovered the report, and I've changed all these names to for confidentiality purposes. When was it discovered? When did it occur? And so these are filled in. Those tabs have turned green. A description of the event. In this particular event, the employee entered incorrect reaction results when an inappropriately overrode a QA failure when doing a blood type. So there's a comprehensive description, a small occurrence summary, and this is something we added at the request of the FDA, and Nouvation was nice enough to add this field. What immediate corrective action was taken? What did you do to correct this problem to make sure no further damage was done? Then we have an employee tab. Who did the preliminary review of this error, and who did the more comprehensive follow-up investigation? Who was the employee responsible? Now, in the blood bank system, we actually sit down with every one of these and we create an employee statement. Typically, whoever is leading that will do the writing, and it's the employee, sort of a summary of what happened, and the supervisor and employee discussion and agreed upon actions to prevent the recurrence. And in this particular case, through this discussion, we determined that this employee was actually not trained or did not fully understand this particular QA warning. What SOP was involved, and in all of these fields, if you're going to attach supporting documentation, you can either print out all their hard copies, or it has a capture capability to scan documents into this report and store them electronically, or to browse to something on your hard drive or your shared drive and attach it that way. So OTIS does have the capability of being completely paperless. This I mentioned when we were talking about our Just Culture. We put out a staff notice, an email to the entire staff, and we actually insert a copy of that notification into OTIS. This is the unit information, so if there was a unit involved, including the ability to say whether or not there was a market withdrawal or a recall involved, what the immediate disposition was, and a copy of that market withdrawal recall paperwork. So what factors? In this case, there were really two. The employee made a human error by entering the reaction results incorrectly, but really wasn't competent, did not understand the QA warning. And you notice that this is red because we selected competency testing. I'll get to that in a moment when we get to corrective actions. Then you select a deviation code, and these are based on the FDA BPD codes that you're used to seeing. So you've all seen these before, for the blood bank anyway. So those are selected. And you notice that this tab is still red for contributing factors. That is because we determined this was competency, and we have to document that this employee has been retrained before this particular tab will be complete and turn green. So this is how OTIS can help you ensure a complete and accurate investigation and drive corrective action. Was this reportable, yes or no? If you choose yes, it starts a 45-day clock and will remind you to get that reported to the FDA. And when you do report, you'll document the date reported and the confirmation number, and you can attach a copy, scan a copy, or just say that the copy is available. So corrective actions. So let's go back to the factors. You'll notice I chose human competency. This tab is still red. As soon as I've completed that employee training, this tab is now complete and turns green. So similarly, if it was a no or inadequate SOP, if I chose that, it would require me to document that the SOP had been revised before it would turn green. So revision of SOP, in this case, it's not applicable. Now this tab is complete. The I status falls off, and the LED turns green. So that's a little bit how the OTIS blood bank system works. Let me show you just a couple of other features. 1926. So this one was an employee that got a positive platelet bacterial detection culture, but didn't appropriately quarantine all the components. And again, when we sat down with the employee, they told us that they looked at the SOP, but they didn't see anything mentioned about looking for other components that were drawn by apheresis. So we had implemented apheresis red cells, but not updated our positive bacterial detection SOP. So they just quarantined the platelet, not the red cell that was collected from the same collection. And so for the factors, it's no or inadequate SOP, and you'll see that this is still red, the LED is still red, so we have to go to our corrective actions and say that we have now revised that SOP, and we typically will put a little description of what the revision was. And once we say that SOP has been revised, then this particular tab turns green and we're good to go. So the last feature I wanted to demo really quickly in the OTIS blood bank is the reminder to report. So in this particular occurrence, this was a post-donation travel problem where had we known about this donor's travel at the time of the prior donation, they would have been deferred from donating. So this was the unit that was involved. You can see that it was transfused prior to discovery, and that we did initiate a market withdrawal or recall. And in this particular case, this was considered a reportable event. So we haven't filled in date reported or the FDA confirmation number, so that tab stays red. And when I go back to the log, the next time I go in, I'm going to get a reminder that this report is due by November 7th. So every time I go into OTIS Blood Bank, the system is going to remind me, hey, you've got a reportable, here's when it's due. So that's very helpful. Now, when the FDA comes in and says, I want to see your last 10 reportables, it's very easy to come to your log and do a sort on the reportable column and do a little mini report on screen, and just they can cursor through your last 10 reportables. So it's a great organized system. The final product that you're going to see is a actual paper report. You can print that out, or you can stay paperless if you desire. Okay, so that's a good look at, or a quick look at OTIS Blood Bank. So the next thing I want to show you is the OTIS Lab product. So I've clicked over to OTIS Lab, and OTIS Lab is a little different from OTIS Blood Bank. It doesn't have some of the fields like the employee statement. We don't do that with every one of the OTIS labs. Doesn't have the BPD reminder, FDA codes, things like that. But it does have we do code every one of these, and the nice thing about OTIS is you can build your own codes, as I mentioned before, for each section or for something you want to track that comes up during the year. So it's very adaptable. You can even use it for HPC laboratories. You can build codes. This will adapt or work just fine for a HPC or a stem cell processing laboratory or even industry, because you can build your own codes. It's very adaptable. Okay, so just want to show you in the OTIS Lab product, don't have time to do a lot of demo, but just how easy it is to trend. For example, I can set the date range down here. So let's say I want to look at a year's worth of data. So we're going to look at August 1st, 2013 through August 1st, 2014. It gives me a count after I refresh with that date range. We're now down to 2,748 reports, and if I want to know which departments reported during that year, I can click on the follow-up department, do a quick count, and it quickly gives me the percentages of each department. So 36% were venipuncture, 16% pathology, 14% our Irvine facility, 10% transfusion service, etc. Now, if I wanted to do a little deeper dive and just look at microbiology and wipe the slate clean from the other departments that I'm looking at here, I can do a filter. So this is the filter screen. You just click on the filter button. You can filter on any of these predefined fields down here, including patient medical record number. You can filter on the follow-up department or any of the deviation codes, SOPs. You can even do a free text filter on the description. In this case, I'm going to filter on the micro department, so I type in the word micro up here. I choose follow-up department. I say apply. I close. And now the only thing that's on my log is the microbiology department. And I can quickly take a look and see what their major reports have been throughout the year by just sorting on the Code 1 column. So I'm going to click the Code 1 column, and I'm going to do a quick count. And you can see the codes down here. The number 1 was the pre-analytic 0904, which happens to be incorrectly labeled specimens from nursing, incorrect results due to data entry error, routine test not done, delayed, etc. So this is an easy and quick way. You can see how fast you can get trend reports. Let's say that I'm sitting down to write an evaluation, and I want to know which employees in the microbiology department were having problems with non-conforming events. I can click on the employee 1 column, do a quick count, and I can see employee 47,683, or I could do a trend by employee number, and I'll show you that here in a moment as well. So let me refresh this and get out of the microbiology department. Now I want to know throughout this year how many mislabeled samples did we have, and I can go back into my filter. I happen to know that the code for mislabeled sample is pre-A0902, and that's deviation code 1, and I can click apply, and I can see very quickly that I've had 40 mislabeled samples. These are RN draws, and I want to know what nursing unit are these happening on. So I just click location, I click quick count, and I get a very fast display of where this is happening, labor and delivery, ED, and etc. So this is just a really quick way of getting trending data without having to write a crystal report. It's all click and go. And then I just want to mention these are all exportable. You can export the entire log into a Excel spreadsheet and do a pivot table if you prefer to track and trend that way. So I think that is pretty much it, and I'm sure Nouvation will be happy to do a much more in-depth and better look at OTIS than I did, but I just wanted to give you a quick demo. So CLSI has a document on the desired features of an electronic event management system, and I really think OTIS satisfies all of these. And again, I'm not trying to sell you the product, I'm just an enthusiastic user of it. So in conclusion, NCE program is certainly required by all the regulatory agencies. BPDs have increasingly become an important part of FDA investigations. So if you're a FDA regulated site, make sure you're doing a thorough job on your BPD reports. I really believe that developing that just culture is the key to success, and developing that culture can take time, and it takes constant reinforcement and feedback to the employee. I think that having done these on both paper and in an information system, and the occurrence tracking information system is the way to go. It brings really order and structure to the NCE process. It really drives and dictates and makes sure that you do a thorough root cause analysis. It provides the ability, as I quickly showed you, or briefly showed you, to trend large amounts of data, and certainly helps fulfill your regulatory requirements. And as I've been talking all along, the ability to easily trend this data is really important for risk assessment. Where is our system at risk, and where are our patients at risk? Identifying needs for system changes and helping keep SOPs current. Providing audit data for nursing units and feedback to our customer groups can be an objective assessment of employee performance, certainly to select KIQs and prioritize quality improvement processes, and provides data for capital equipment justification. So just want to end with a mention of Roger Boisjoli. He was an engineer at Morton Thiokol, and he is a Scientific Freedom and Responsibility Award winner. He was the engineer that tried to tell his superiors that there was going to be an accident because of the solid rocket booster seals that weren't working at cold temperatures. And he kept pointing this out and predicted what was going to happen, and nobody listened to him. And during the Presidential Commission report that investigated the shuttle accident, they concluded its faults were a lack of problem reporting and inadequate trend analysis. So it's very important in having a safe system for your patients. And with that, I thank you and turn it back over to George.
And I thank you too, Randy, for doing such a great job on this. And for those that would like a fuller demonstration of OTIS blood bank or OTIS lab, please give us an email, and we'll take 50 minutes to show you all the wonderful OTIS features. And thank you so much for taking time out of a busy schedule to come and join us today. Thank you very much.